morning, everyone. Welcome back to day 2 of the Canadian Cannabis Summit. If you were with us yesterday and you made it back for day 2, I think that means that you enjoyed day 1. We've got a lot of great content, a lot of great speakers today. And we're starting with Dr. Ahmed, who has a wonderful presentation to share with you. Dr. Ahmed is a practicing clinical anesthesiologist in Alberta and Ontario with specialist training in interventional chronic pain management and cannabinoid medicine. Dr. Ahmed is an expert in prescribing medical cannabis for chronic pain and associated diseases via the ACMPR and has done research on over 50 strains of cannabis provided by licensed producers. Her passion to share her knowledge on medical cannabis has established her as a CME medical educator for physicians and allied health professionals regarding medical cannabis use in Canada. Today, she shares her insight on the changes occurring in cannabis legalization and its effect on public health, the cannabis industry, as well as physician practices. It's my extreme pleasure to introduce Dr. Ahmed to the stage and to learn from her expertise.
Good morning. Thank you so much. It's great to see so many people here this morning, giving me an opportunity to share my experience as a physician here in Alberta. I am very privileged to be here, so thank you. So this is a very big topic, and I'm going to probably skip through quite a few slides, just so that I can get to the parts that I really think are important for public knowledge. Essentially, the learning objectives for this presentation are for you to be able to understand the difference between the ACMPR and Bill C-45, as well as understand what the endocannabinoid system is, and last but not least, to have some clinical pearls about how to apply your knowledge to using THC and CBD. One of the biggest challenges that I have faced in my practice is that we are in an opioid crisis, and due to this, many physicians are reluctant to use cannabis as a tool in their toolkit. And I truly believe that cannabis is an exit drug. So, what is the access to medical cannabis for medical purposes? Currently, in our country, we have had a variety of documents that have been provided by the government so that medical physicians could become authorizers for cannabis. And currently, the only way to be able to get access to medical cannabis is through a physician's office, through a medical document, which will allow a patient to receive medical cannabis products from a licensed producer. As of yet, purchasing cannabis from the street, a dispensary, a grow-op, or an online shop is actually illegal and is unable to really be quantified as a safe product. What is interesting, though, is that most people don't know that if you purchase ACMPR products, you're not limited to dried flower and extracts of oils. You're also able to purchase seeds as well as live flowers. And there is a licensed producer in BC that actually advertises this on their website so that you can access to it. So a little bit of the history. Oh, sure. Perfect. Thank you. So with regards to the regulation and the history of medical cannabis, the difference between what we are currently in and where we were before is that all of our behavior was based upon the Supreme Court ruling that took place back in the early 2000s. And so essentially, the reason why patients were able to grow cannabis was the fact that that was the only way patients actually truly knew how to self-medicate. And so we have evolved from that because Harper's government, back in 2011 and 2013, developed the MMPR. Now, the MMPR was the only way to have licensed producers sell dried flower to patients, and it was allowing for the opportunity for the government to be able to regulate and create public safety. The concern was obviously that under the MMAR, it was hard to be able to recognize what was black market and what wasn't. And so the issue that was arising out of the MMPR is that it wasn't allowing for full freedom because the licensed producers were too expensive. If patients had previously been growing and were having to spend less than $3 a gram, and now we're having to spend between 10 to 15, it was again becoming a violation of their Charter of Rights. So the ACMPR came into existence in 2016 to allow for that opportunity for patients to again grow again, but it also allowed for the opportunity for people to be able to have extracts as well as oils. Now, we're still very behind when it comes to concentrates and extracts, but we've made leaps and bounds since 2016 when Health Canada started approving the opportunity for patients to access cannabis oils. Now we're moving into Bill C-45, which is the Cannabis Act, and everyone has many questions about this. And I wanted to go through the difference between the ACMPR and the Bill C-45. So currently, unfortunately, cannabis is still not an approved therapeutic as per Health Canada, but they have created an opportunity for patients due to the fact that the government was being forced by the Supreme Court. So we're very fortunate here in Canada that we have a judicial system that actually encourages an unbiased way for patients to be able to get access to their medication. But in realm of this, right now, the only legal providers of medical cannabis are licensed producers, and I feel many people are still unfamiliar with what this means. And the challenge is because we're still living in a time where accessibility is very challenging for patients. And due to this, many patients have become self-advocates, self-medicators, and then also wish to empower and share with other patients. And that's where the online dispensary realm has come about. And it's due to that fact that the government is trying to regulate this, and so any of those purchases currently are illegal. However, if a licensed producer is able to sell to a dispensary, and it will be through the provincial system, so the point over here is Bill C-45 is a piece of government legislation that would legalize access to cannabis. The bill would control and regulate how cannabis is grown, distributed, and sold directly to the public. It will not protect or allow cannabis dispensaries to continue selling. And essentially, licensed producers will be able to sell to provincial authorities to distribute and resell cannabis and various cannabis products. And the distinction with this is that a lot of people currently are still using various concentrates. And yesterday, a colleague of mine was having a conversation about how concentrates and extracts are the direction where cannabis is going, but our government is very behind. And I agree. However, it's still very necessary right now for the conversation to be taking place. We're all familiar with what's happening in the Senate right now, and due to the confusion of what we can see the mass public is going through, education really is the key here. So a recap. A patient has to be consulted with an authorized health provider. The health provider has to provide a medical document, and many physicians are reluctant to do so. And then the patient has to register with the licensed producer. Those medical documents are then verified by the licensed producer. And then the patient is able to go online, create an account, and order online and have it delivered to their home. I'm going to stand up because I'm having to turn around a lot, so I'm going to stand and push myself back this way. I hope that's all right. Yeah? Perfect. I tend to walk and talk, so I hope you guys don't mind. So what are the medicinal components of cannabis and how are they thought to work? Well, the cannabis plant has 2 genuses, but really at this point, the botanists that I speak to share with me that we really don't know what a sativa is. We don't really know what an indica is. But essentially, if you think about a sativa or an indica, you're essentially looking at the terpene profile, and I'll get into the terpenes later on. But when it comes down to plant morphology, the key difference here is essentially that the plants have a different shape. One is darker in color, one is more tall and narrow, and the way it grows. And this concept about nighttime use and daytime use truly comes from terpenes. So what's in cannabis? Well, we all talk about cannabinoids. And here I'm also going to share about with terpenoids. Now, terpenoids for me have become a huge fascination because I have found that while I've been studying how cannabis works with my patients, the varying degree that I've noticed always tends to be with the terpene profile. And as research is now furthering in cannabis, I've been validated because a good colleague and a mentor, Dr. Ethan Russo, actually published a paper called The Entourage Effect, and I'll get into more details about that. So the endocannabinoid system identifies that we actually have molecules in our body called endocannabinoids, and this was discovered in 1998. And that's shocking because if you think about it, we've actually have an ancient system with receptors and molecules that we did not even know existed until about maybe perhaps 40 years ago, 20 years ago. So for me, at this point, what we're looking at is trying to figure out how to use phytocannabinoids because we know that we have an existing system. Now, phytocannabinoids essentially means that we are extracting the cannabinoids that are going to be able to mimic or replenish the existing endocannabinoids that we have. Last but not least, we have synthetic ones, and common synthetic ones that I have in my practice is something called nabilone and the other one called Sativex. All of these all bind to CB1 and CB2 receptors. I'm having a bit of a technical difficulty. Oh, there, I fixed it. Thank you. There was an update. So as I was mentioning, the human endocannabinoid system is a very ancient system and has a very important regulatory aspect throughout our body, specifically when it comes to our homeostasis. So what is homeostasis? Homeostasis is cell balance, and when we're stressed out, we're not in balance. That's when the endocannabinoid kicks in. Stress states include pain, anxiety, and having any sleep disorders. And as you can see here, the endocannabinoid system is robust. It's very robust. It basically has a huge central role in our central nervous system, but it also is in our immune system. And due to that, it has a huge impact on just not only pain management, but neural development, metabolism, bone development and bone density, regulation of stress and emotional states, and of course, psychomotor behavior. The two main receptors are CB1 and CB2. These are primarily found in your central nervous system and your peripheral nervous system. And it's found in the lung and skeletal muscle and smooth muscle, which is interesting because as a female who treats a lot of patients with chronic pelvic pain, there's a lot of CB1 receptors in the uterus, as well as in the testes and the gut. It modulates pain, movement, emotion, feeling nauseous, and also seizure thresholds. With regards to CB2 receptors, these are also found in the CNS, but they're also found in our peripheral organs, especially cells associated with our immune system. Since the endogenous endocannabinoid system exists, using exogenous cannabinoids, such as the plant-based, may be beneficial as a therapeutic option. So what exactly do we know about cannabinoids? Well, we all talk about THC, and I'm here to talk about THC and CBD, but I'd like to share with you that we actually have hundreds of cannabinoids. There's new ones that we're discovering, like CBV and CBN and CBC. And I had the fortune of actually meeting the lady who discovered CBG, and it was actually named after her. I don't know if many people in this room know, but since the late 70s, the National Institute of Health in the United States has been studying cannabinoids and actually has a patent on CBD and has been growing CBD plants in Ole Miss University. It's a fun fact that I learned when I was in Denver back in January. The point here that I'm wanting to share is that the ratio and concentration of THC and to CBD is the key here when it comes to its medicinal and therapeutic benefits. As well as I was mentioning to you before, there's something called the entourage effect. The entourage effect essentially is stating the benefit of the whole entire plant. Now, the whole entire plant includes the cannabinoids, the flavonoids, as well as the terpenoids. And the botanists are now saying that the hypothesis that we've carried for so long, that it had to be high THC to get the medicinal benefit, has now been debunked. Health Canada identified that, we have to grow some CBD, and so the licensed producers that have mixed CBD and THC strains thought that this was the medicinal benefit, and now that theory has been debunked. We're essentially operating out of a fact that the mixture is the medicine, and so having the terpene profile is very important because the terpenes actually enhance the way THC and CBD cross through the blood-brain barrier and are able to actually bind to the receptors in our brain, which primarily are the CB1 receptors. So speaking about THC, and I'm going to go a little bit quicker about this, but essentially, the key thing here is the muscle relaxation. What I've noticed with THC in my practice predominantly is that people who are suffering from chronic pain have a lot of MSK pain. And the THC that is associated with high myrcene is a terpene which helps with muscle relaxation. It's often known as an indica. And indica strains tend to be very alleviating of pain because they also have a sedating effect. And that's because the CB1 receptors, as I had mentioned to you earlier, are predominantly found in the central nervous system, and THC predominantly binds to that receptor. When it comes to CBD, everyone talks about it being non-psychoactive, and I wanted to educate everybody here that it is psychoactive. What does psychoactive mean? Psychoactive means that there is a molecule, be it medicinal or be it endogenous, that crosses through the blood-brain barrier. So any molecule that can cross over the blood-brain barrier is considered to be psychoactive. In this instance, what we are identifying is that it's not intoxicating. And I'm still really reluctant to use the word intoxicating because I do not believe that THC intoxicates. So we're still trying to figure out the nomenclature and how to educate. But the key here is that CBD and THC both are psychoactive, but one has a alteration of psychomotor associated and one doesn't. And due to that very fact, CBD is a natural antidote to THC, and I will get into this further on. So the terpenes, or the terpenoids, they're currently being studied extensively, and the people who are actually probably the leaders in this are craft growers coming out of BC, Alberta, and Ontario. And that's because craft growers have been identifying the various strains based upon their scent. So terpenes are the aromatic oils, and it's the female plant that essentially is preventing the plant from getting pollinized. So terpenes, in combination with the cannabinoids, basically create a very pungent scent to repel insects, to avoid pollination. And it's these terpene profiles that enhance the cannabinoids as humans when we consume them. Again, as I mentioned to you, there are studies taking place, but because of it not being legal, we don't actually have enough knowledge in this space, and it's an area of medicine that I'm genuinely very interested in. But a fun fact for all of you to know, terpenes are part of your life currently. And the reason why you don't know about terpenes is because the industry doesn't care for it. We have been interacting with terpenes in our skincare, in our shampoo, and in our cosmetics for the last 50 years. And that is because terpenes add aroma. Anyone remember the Zest commercials from when we were younger? So Zest, giving you the energy, giving you the ability to feel fresh in the morning. Well, if anyone smells a soap of Zest or even Irish Spring, they will identify the terpene called pinene. Pinene, coming from pine, has an ability for being able to enhance mood, improve cognitive function, and increase clarity. Fascinating, isn't it? Same way at the other time, linalool, which is found in lavender, is known to be a sedating and calming terpene. And that's often found in a lot of calming lotions that are scented with lavender, because linalool is the terpene that has been added to be able to allow patients and babies and mothers to use lavender-infused products to help them relax. And then when we talk about myrcene, which is this sedating terpene, it is associated with also chamomile. And how many people have heard of the, common tale of drinking chamomile tea to help themselves relax and go to sleep? Again, identifying that myrcene is high in this. Now, hops also has high myrcene in it, and I also want to bring up the fact that we have alpha-beta caryophyllene, and these are found in pepper, and it is a unique terpene because it also crosses the blood-brain barrier, and due to this, it has its own modulatory effect. And when I think about the fact in chronic pain, people talk about capsaicin, which is a topical analgesic coming from the capsaicin plant, better known to us as cayenne pepper, which again is a pepper. It makes me understand we're talking about alpha-caryophyllene again. We're talking about alpha-caryophyllene, which is a terpene in pepper and has variations that are going to be coming from different countries and different continents. And we both, all of us and me, know that a lot of our plants come from Asia. And so the initial hemp plant came from India, and so does cayenne. So why is this important? And this is really near and dear to me, and I'm going to put a little bit of focus on this. I wanted to point out the news items that have been coming up in my emails. I don't know if many people do this, but I had a good friend share with me how to set up Google alerts onto my email account so that I can get the latest updates on cannabis and chronic pain across the country and I don't have to go hunting for it. So once in a while I'll go through my digest and I'll get information and it keeps me in the loop. It's really difficult to keep in the loop because the industry is moving so fast. But you can imagine how I feel as a physician who's a specialist in this when they say specialists worry about the effect of legal pot on budding minds. Oh my God, where are we? Last but not least, cases of dogs made sick by cannabis seem to be on the rise, Calgary vet says. Well, this is really important for us to know. And last but not least, this is the most latest that I had seen. Top Calgary ER doctors see spike in cannabis poisoning. Yes, I know. So we are the enlightened ones, and we're the ones only talking to each other. We need to engage with more and more people. It can't just be us who are wanting to have this conversation. Wanted to give you some quick facts. Over 250,000 Canadians are going to be legally accessing cannabis as of June. By 2024, the prediction is close to 500,000. Physicians need to respond to the growing need of patients wanting access to cannabis. And as you can see here, there's 85,000 doctors in Canada. 3% are prescribing for 250,000 of them. 3%. That means that it's approximately only 2,500 doctors. And out of those 2,500 doctors, I am one of 200 that are actually engaged and specialists in conversation with colleagues in the United States and Europe so that we can advance our knowledge so we can take care of our patients. And I'm now coming to understand that I'm actually one of 20 doctors in the entire country that has specialist understanding of cannabis. And it's quite remarkable for me because I thought actually I was one of many. But it's quite a privilege to know that I'm actually an industry leader at this point. But what's understanding for us in this room, but is a misunderstanding for the doctors, is that they think that Bill C-45, the Cannabis Act, will obliterate the need for a medical system. The CMA thinks that there's no need for patients to go to a physician and get cannabis because you can just go to a dispensary that the licensed producers send patients to, licensed producers send cannabis products to, and are essentially saying that, you go to Walmart and you buy your NSAIDs and you buy your Tylenol and you can buy your vitamins, you can go to your dispensary and buy your cannabis. Doctors don't need to be involved. And it really created quite a stir back in April. I was attending a conference in Toronto called the CCIC, and it was a group of 200 physicians that got together, and we had the vice president of the CMA in attendance. And it caused quite a stir when the vice president of the Medical Association was essentially telling all 200 of us, you don't really need to be here. It's kind of unnecessary. And unfortunately, what is not being discussed, and I think it's really important, is that there needs to be a call to action. We need to raise our medical practice standards. As physicians, we need to familiarize ourselves with cannabinoid medicine. And that's because there's enough research to prove that cannabinoid medicine works. We're just unwilling to recognize it. And so what I really want to encourage everybody here is that you should be having a conversation with your family physician. You should be having a conversation with any physician and asking them, are you familiar with cannabis? Why should you be familiar? Well, because there's headlines in the newspaper saying pot poisoning, young minds getting corrupted by cannabis, pets having toxic doses of cannabis. You're the people who are supposed to know everything about our body. Why don't you know about this? It opens up a conversation that we need to also recognize that physicians are burdened. They're burdened by having to know too much in too short periods of time. And the endocannabinoid system, I'll frankly tell you, is not taught to physicians. It is not part of the medical school curriculum. It was not taught to me. I had to do this all by myself. I took time out of my practice to develop this knowledge. I am privileged that I was able to do so, but my colleagues aren't. So we need to create a familiarity so that the language that they are actually learning is coming from a space of education. particularly since recent surveys are identifying that more and more Canadians are going to be interested in cannabis, and they're going to look for advice. And I applaud my colleagues in pharmacy. I applaud my colleagues in nursing who are stepping up to the plate and saying, you know what, we'll take that role on. But I'm very leery as well because, frankly speaking, when the Pharmacy Association about 5 years ago said, no, we're not interested in cannabis, and it took Loblaws to purchase Shoppers Drug Mart, and the CEO of Loblaws say, you know what, I want to sell cannabis, that the Pharmacists Association became involved finally. It's really important to keep yourself informed. Politics are something that are actually going to shape your opinion, but it's most important for you to actually have the knowledge so that your opinion isn't swayed by just media. We need to take advantage of Canada's unique global position. The entire world is watching us. They're waiting for Canada to legalize cannabis, and then they want to see the show. They want to see if we're going to all go crazy. Come on, that's really basically it. Are we going to normalize ourselves, or are we going to become an abnormal population? The US is betting that we're going to go crazy, but I'm betting that we're actually going to have peace. We're going to actually have more dignity. We're going to have more compassion, because in my specialty practice, that is what I'm identifying. I'm identifying empathy, compassion. I'm identifying humanity, because people are coming together wanting to help each other because we don't want to suffer anymore. And it's very important for our physicians to acknowledge that they have the same values as we do. So what is the evidence? And I'm going to really skip through this, and I would love for someone to keep me on time because I do want to have an opportunity for questions. So Health Canada acknowledges that there's a wide variety of potential therapeutics, but they will not say that it is actually an approved therapeutic. So we're in a conundrum. Patients will come and say, I have PTSD, I have pain, I have MS, I have neuropathic pain, I have sleep disorders, I have anxiety, I have an immune issue, I have cancer, I have Crohn's, I have, ankylosing spondylitis. And the problem that we're facing is that we don't have a large body of evidence to support all of these claims, but there are some key evidence-based studies that are able to distinguish certain key points. And I want to point those out for you right here. In 2017, there was a comprehensive review by the National Academies of Sciences, Engineering, and Medicine. They did a literature review from 1999. So remember, the endocannabinoid system discovered in 1998. 1999 is when they started the research. August 2016, they had about 250 articles. Can you imagine? Like in less than 20 years, only 250 articles. But the conclusive substantial evidence of efficacy, and this is the key, came up for treatment of chronic pain, treatment of the induced nausea coming from chemotherapy, and improving MS spasticity. Moderate information about improving sleep outcomes, particularly in sleep disturbances associated with sleep apnea, fibromyalgia, MS, and chronic pain. But there was limited evidence when it came to any sort of psychiatric disease, when it came to any issues when it came to the immune system. However, lo and behold, as of 2016, a study was demonstrating that patients are using cannabis as a substitute for prescription drugs, particularly for opioids, for benzodiazepines, and for antidepressants. And this is independent of whether they identify themselves as medical or non-medical users. And this is especially true if they suffer from pain, anxiety, and depression. And this is especially true in my practice. So, the latest news, the College of Family Physician Guidelines. And I on purpose did this because I really wanted everyone to see this. Do you see this thing right over here? So the guidelines, why do we have guidelines? Okay, let me just clarify, I need to clarify this. So family physicians, the most burdened physicians in our entire country. They give you 5 minutes and they have to figure out everything. Tough job. If they get 10 minutes, it's a luxury. If they have a half an hour, they consider it to be a great day. So in 5 minutes, they need to make a snap decision if you're a referral, If they're going to treat you, or if they're giving you a script, or if they have to do an advanced procedure and do some more lab work on you. In that process, we have negated the fact that physicians need to engage with the patients. They need to listen, they need to hear, and that the patient is part of the conversation. Interestingly, the Royal College actually has something called the CanMed rules, which is specific for specialist physicians. And part of it is that you have to be making part of a shared decision-making model with your patients. Well, a shared decision-making model means you would respect the patient's values and their needs and incorporate it into your practice. Well, in 5 minutes, how do you do that if the patient can't even go, I think I want cannabis? They can't even say it. And the reason being that we have to have algorithms and protocols is because we have an aging population, we have diseases like hypertension, we have diseases like diabetes, we have diseases like COPD, we have diseases like liver disease and kidney disease. And to be able to identify the lowest common denominator, the person who could die, the risk of someone actually having complications, means that there needs to be an algorithmic process that you don't miss something. And it's the way for a physician to ensure that they're delivering good care. So the College of Family Physicians decided, you know what, we're going to do it for cannabis. And they reviewed the same literature, but their answer was that they didn't think that there was an answer. They don't believe that cannabis can be used for pain management. They don't believe that cannabis can be used for MS spasticity. And so what this slide is demonstrating to you is that if you keep saying yes, you're considering it, yes, for pain, palliation, chemo-induced nausea, vomiting, or spasticity, yes. Have you tried more than 3 medications? Have you tried more than 2? Are they refractory? Yes or no? Recommend against use. No, you don't need cannabis. And I unfortunately have cut out the bottom part. I really should have kept it. But the bottom of this, it also says recommended against. So no, cannabis is not an option. It hurts me. It hurts me a lot because as a specialist who is basically working really hard in her practice and doesn't get enough opportunity to share her knowledge, I'm being told that what I'm doing doesn't make any sense to them. But they're neglecting to understand that my sample size does not need to be 2,000. It does not need to be 50,000. I need a sample size of 1. If one human being is benefiting from my intervention of getting them off of opioids, of getting them into a state of better sleep and improving their pain, that is a success. That means they deserve cannabis and they should be on cannabis. And that's very unfortunate that other physicians aren't understanding this, but it's because they have been protected by the guidelines, by the algorithms. It's easy now for a physician to say no. Wanted to share with you, on the other hand, the good news. Practical considerations and guidelines from cannabinoid medicine prescribers. My good friend Caroline McCullum and our mentor, Dr. Ethan Russo, published in Europe, because in North America we're still a bit behind, practical considerations. And the opening line, cannabis has a superior safety profile in comparison to many other medications with no recognized deaths due to overdose. THC-mediated side effects are dose-dependent. Use a start low and go slow dosing strategy will mitigate any adverse effects. Combining CBD with THC can further reduce side effects. Patients develop tolerance to the psychoactive effects of cannabis quickly without concomitant tolerance of the medical benefits and maintain the same daily dose, which is in stark contrast to opioids. And so they go into further guidelines. In this presentation I had done for other physicians, but the key here I found very fascinating was that Caroline and I practice the same way. I actually had already developed these exact guidelines in my practice because you identify it very quickly. It doesn't take rocket science to understand how to be compassionate and caring towards a human being. So, how do you start cannabis? You start at 2 to 2.5 milligrams, and I highly recommend this. And that is because in a naive user, if you go too high, they are going to be uncomfortable, especially in the daytime. You can increase it to 2.5 milligrams twice a day. And this is equivalent to taking 0.1 or 0.2 milliliters of cannabis oil, because cannabis oil, as per ACMPR regulations that the government has, cannot be more than 30 milligrams per milliliter. And due to extraction processes, the maximum that they can actually get due to that limitation is between 20 and 25. So do the math. 20 milligrams per mil, 0.1, 2 milligrams. 0.25, 2.5. You increase it as needed, and you can go up to 15 milligrams. Divide it up in 2 to 3 doses in the day. That means you go up to 5 milligrams twice a day or 3 times a day. Another very reasonable amount. Doses exceeding 20 to 30 milligrams will create adverse events, but they may actually induce tolerance too. So what do you do for nighttime sleep? Well, same thing. Nighttime 2.5, 1.25 in the elderly. And then if they tolerate it, you increase it every other day. Well, I'm a little bit slower than that. Why? Because the medication is expensive. So I wait for my patients to tell me it stopped working. It takes about 3 months, 4 months, maybe 5. And usually it's because they got tolerant to the terpene called myrcene. And all I have to do is change the company and they're 0.25 again. 3 vital Canadian health needs. I think we all agree here. Restorative sleep. We are craving sleep as a society. We are inundated with our computers and our tech. So what's the evidence for sleep disorders? Dr. Russo is brilliant. He was so fed up with the US, he took off to Czechoslovakia and England so he could do his research in cannabis. And while he was there, he got approached by GW Pharma, who decided that they wanted to study plant organic THC and CBD ratios to understand how best to use it. So they're industry leaders. And his conclusion is experience to date with Sativex. And Sativex is the pharma equivalent of cannabis oil in a ratio of 2.5 milligrams of THC to 2.5 milligrams of CBD. The phase 1 to 3 studies in 2,000 subjects with 1,000 patient years of exposure demonstrate marked improvement in subjective sleep parameters in patients with a wide variety of pain conditions, including MS, peripheral neuropathic pain, intractable cancer pain, and rheumatoid arthritis, with an acceptable adverse event profile. And I'm going to go through this, but the key thing here is this number right over here. In the medical literature, when you find a p-value that is less than 0.005, it's considered statistically significant. So to be statistically significant, that means that you have mitigated all biases. You have removed all of the confounding factors. And independent of it, you're demonstrating it still works. Statistically significant. Sativex, statistically significant. Nabidolex, which was their CBD, and Tetranabinex, which was their pure THC, not statistically significant. Well, guess what? I already knew this because in my patients who I challenged to help go to sleep, I give them a combination of THC and CBD on purpose. I didn't know this study when I started my practice. I didn't have time to sit there and study everything. I knew I couldn't kill my patients with cannabis. I just had to start because no one was doing it. So incidentally, I already knew this. The abuse potential and psychoactive effects of delta-9 tetrahydrocannabinol and cannabidiol oral mucosal spray, Sativex. Disturbed sleep is a cause of much distress and additional morbidity in many chronic diseases, and there is evidence that Sativex consistently ameliorates this. The authors of this review speculate that this is probably due to nocturnal symptomatic relief rather than a direct hypnotic effect. How fascinating. All of our sleeping pills are hypnotics. How do I know this? I'm an anesthesiologist. Trust me, I know all about the pharmacology of putting you to sleep. Cannabis works independently of a hypnotic state because it alleviates the symptoms that you are suffering from that are preventing you from going to sleep. How important is that for our health? It's very, very important for our health. So the conclusions. Sativex, which is the pharma equivalent of CBD and THC oil. Very expensive. That's why we're so lucky to have our LPs here, because we can do it ourselves. We don't need a pharma product. But this is my confusion. If Sativex has been studied and they have proven it, and I can see that Sativex is like CBD and THC oil combination, why are physicians not acknowledging this? It baffles me. It really, truly baffles me. What's another vital need? Normal autonomic nervous system response to stress. All of us experience stress. All of us experience anxiety. We live in a stressful time. The industry of technology has completely revolutionized our ability to share knowledge and also sensory processing. We are inundated with so much information. And if as adults we are struggling, we can only imagine what our youth are going through. The rates of mental health issues that are rising in Canada are obscene. The rates of teenagers wanting to harm themselves is obscene. The number of hospitalizations in the emergency department for young women having anxiety attacks is not fair. It's not fair. And we're labeling them. We're labeling them with diseases. We're not acknowledging that they're struggling because they don't have the coping skills to deal with the stressors of this life, because time's moving too fast. So I wanted to learn more about CBD, because everyone's telling me, oh, CBD this, CBD that, CBD this, CBD that. And so really, what is the reason why CBD works? So really quick study here. They were wanting to identify the effects of CBD on the cerebral blood flow. And the key thing here that I wanted to point out was this word called the HPA axis and the amygdala and the hippocampus and the prefrontal cortex. We have an adrenal system that is regulated by our hypothalamus as well as our pituitary gland. There's a specific axis. And the rationale for that is because we're all animals. We have a primitive brain. Our primitive brain has 4 major functions to protect us. So we fly away or we fight to be able to continue to grow. So we therefore feed ourselves. And then to propagate our genetics. So then we procreate. As an animal, the distinction that is different for us is that we have higher cognitive functioning. We have a frontal cortex that is overly developed, so we have conscious thought when it comes to when we want to eat. We have conscious thought about when we need to defend ourselves. But in moments of acute stress, the primitive brain takes over, and we are unable to think about what we need to do next. And this is because our amygdala is more developed in humans than it is in animals. And that's our memory reprocessing center. And it has an inhibitory and excitatory effect on the way we recall memories. So how many people here this morning would remember what they had for breakfast and if it was good or bad? Probably everyone in this room would say, yeah, sure. Not really a memory that I'm going to keep in, but someone cut you off on Crowchild and scared the out of you, you're going to remember that. And that's because that negative feedback is allowing you to remember that that surge in heart rate, that surge in fear was associated with danger. And therefore, when someone is going fast on the highway in the future, you get out of their way because you don't want that feeling again. Same thing for positive. You pick up your children and they're smiling at you and you're so happy with them. That's the memory that you want to remind yourself of. So when you do a cartoon for your children and they hear them giggling, it reminds you that you like that sound, so you'll make jokes yourself. It's positive feedback that way. THC modulates the amygdala and prefrontal cortex. Researchers out of U of C actually are doing animal model studies to demonstrate that THC has an inhibitory effect on the amygdala and an excitatory effect on the prefrontal cortex. But this is a very part of the brain that is so important in the adolescent brain that needs to be regulated through actual learning on how to cope versus suppressing. That is why I agree that the youth should not have access to high THC. However, CBD, as per this study, demonstrates calms the entire system down. Regional blood flow increases in this area. But this was the distinction that I found very interesting. Researchers out of Brazil said that the effects of THC and CBD wanted to be monitored. So they did a really good study. They actually had a placebo, they had THC, they had CBD, and then they showed pictures in a MRI scanner that was a functional MRI, which means it can take pictures of your brain in real time with energy markers to demonstrate how your brain responds. And what they found was very interesting. CBD had a distinction that when you showed anxiety-provoking pictures to an individual who had had 400 milligrams of CBD, the area of their brain, which is called the limbic system, the amygdala, the hypothalamus, and that picture that I showed you earlier, it wasn't lighting up. It was calm. There wasn't this increase in surge that would then result in high adrenaline, which is a feedback of what our chemoreceptors in our hair rises when we're stressed. We don't know this, but it does. They actually done such a sophisticated study to identify this. And so what they basically decided was that CBD had an effect on activation in the limbic and paralimbic regions, which contributed to the ability to reduce autonomic arousal and subjective anxiety, whereas THC did the opposite. Well, how many people here already knew that? Yeah, we all knew that. Last but not least, chronic pain relief. Canada is suffering. 1 in 5 Canadians suffers from chronic pain. 20% of our population is suffering in chronic pain. Post-surgical, very high. Post-surgical pain is probably the biggest challenge that we have because we're doing a lot of orthopedic procedures for knees and hips, shoulders, and they're given Percocet when they leave the hospital, or oxycodone, or oxyneo, or hydromorphone. Why do I know this? Because I was part of that team. I was part of the post-op team of pain management as anesthesiologist. We don't have any other options. And then, unfortunate for the patient, the anesthesiologist who is part of the pain management is no longer part of the pain management because I'm hospital-based. And then it's left to the family doctor who doesn't have enough knowledge about how to use these medications. So they just keep the script up. Don't get me started about the surgeons. 0 deaths, no documented evidence. This is not only by Health Canada, but the DEA, on the website, the Drug Enforcement Agency. No recorded deaths, yet it's a Schedule 1. I do not understand. So, in my opinion, medical cannabis may help mitigate the current opioid crisis. We have the second highest rate of opioid prescribing in the world, and the abuse is on the rise. The annual death rose by 400% in Ontario between 1991 and 2010. And fentanyl and carfentanil, which are advanced products of opioids, have been killing over 2,000 people per year in Canada. We are fortunate our population is less because in the US, it's up to 20,000. Cannabis is a legitimate medication for pain. We've already identified this. So why is it not being recommended as first-line treatment? Why is it being recommended as a third-line treatment? I changed my practice when I came to Alberta. Cannabis is my first-line treatment. Why? Because I'm not going to kill you if I prescribe it. I may cause you to feel altered. I may cause you to get anxious. I may cause you to be sedated, but I know how to use CBD. And I want to teach you that, so I'm going to move really quickly through this now. We're suffering here in Alberta, everybody. Up to 2 people die every day in this province. Why is the Senate not talking about these pieces of information? Why are we not talking about the death rise, the death toll? Why are we fixated on secondhand smoke of cannabis? I worry as a Muslim in this country that if I don't step up and share my knowledge about how to be a compassionate physician and end a crisis that's killing us, then I haven't done my job as a physician. I truly believe that. But why am I talking about this? Because everyone, I'd like to share, Sesamet, Nabilone. Nabilone is synthetic THC. Here in Alberta, It's an authorization medication, i.e. they treat it like a narcotic. When you treat cannabis extracts or synthetic cannabis as a narcotic, you are teaching the public, and most importantly, the doctors, that it's dangerous. But it's not. Why is it not dangerous? And the key for all of you to see here is the bold that I have in this slide. The brainstem. Remember we're talking about the primitive brain? Well, our brainstem is what regulates our ability to breathe, and it regulates our ability to be able to control our heart rate. And it regulates our ability to not have a seizure and go into a coma and die. And so, as you can see here on the slide, CB1 and CB2 receptors do not exist in the brainstem. Therefore, you will not suppress your respiratory system. You will not suppress your cardiovascular system. You will not suppress yourself into a coma and death. But opioids? Opioids will do that. I know that for a fact because I do it on purpose in the operating room. When I push morphine or fentanyl, I'm doing that so that I can ablate every single reflex for you to breathe, because I'm putting a breathing tube in to set you up onto a ventilator. And if you cough when I do that, it's a pretty bad thing to happen. So as an anesthesiologist, we are trained to take over your breathing because we know that we have removed your ability to do so. Why are other physicians not thinking like that? Why do they not think that when I give you this medication, I am taking your ability to breathe? It really scares me. We're not teaching our medical students about how to be actually good pain physicians. I'm going to skip through this because it's redundant. New study came out proving, yes, it works. Quality of trials were excellent. 15 of 18 RCTs demonstrate that it had a modest analgesic effect. 43% of patients reported greater than 30% reduction in pain intensity on a scale of 0 to 10, which is considered to be clinically important, versus 21%. Statistically significant. So clinical pearls from my cannabinoid practice, THC and CBD and how to use it, and this is the part that I really want to focus on. So what do you do first? Doesn't matter if you're a patient, if you're self-medicating, because that's what I think you're doing if you're a recreational user. You gotta set goals for yourself. What is it that you want? Pain management, your function, your mood, your sleep, your quality of life. Ensure that these goals are actually realistic and measurable, otherwise you're chasing. And you don't want to be chasing your medication because your pockets are going to become really light. Things that I have to screen in my office are features of substance use disorder. The psychiatrists have been pushing cannabis use disorder to everybody. We are failing to acknowledge that cannabis use disorder is unregulated self-medication of cannabis. Unregulated self-medication of cannabis results in people heavily depending on a medication because they do not have the coping tools to help themselves with their stress, to help themselves with their anxiety, because their access to mental health is not available. The psychiatrist will prescribe a pill, the patient says, I don't want the pill, and they go off and do their own, because we live in a world of autonomy. We live in a world of autonomy. So yes, I can get the pill from the doctor, but I don't like how it makes me feel, so I'm just going to do it on my own. But I have no knowledge about this. So I'll just use it until I feel better, but I'll overuse it because I don't know my thresholds. And then my body needs it. Well, opioids do the same thing. Alcohol does the same thing. So I actually screen for people who have issues with alcohol and opioids and other things, be it sex, be it movies, be it food, because that means you actually have a problem with your ability to process information through your amygdala, and your prefrontal cortex is not taking control. That's the issue, not the cannabis use. Clinical Pearls 1. So when I talk about this with physicians, I say to them, if someone's got a really bad anxiety disorder, don't start with THC, like foolish mistake, don't do that. Why? Well, it increases your heart rate. Remember that slide earlier when I showed you about CB1, CB2 receptors? There was a space right here in the middle of your chest. So our heart has receptors. If you speed it up, well, guess what? It makes you feel uncomfortable. It's not normal for us to have a fast heart rate, right? If we have a fast heart rate, that means that there's something wrong and we need to escape danger, or we're working out. History of significant pollen, ragweed, or hay fever allergic reactions, such as hives, difficulty breathing, or hypersensitivity reaction to plants. I am probably the only doctor who actually puts this in her slide. Why? Because I actually see it. I have treated enough Albertans that I have seen medical cannabis allergies. And when I say medical cannabis allergies, I say they're allergic to terpenes, because these women are on high doses of Benadryl, high doses of various antihistamines, and are suffering from headaches and pain and all these issues. And they say that, you know, in the summer months, I can't go out into my garden, I can't go anywhere, I get highs all over my body. And the first thing I think is, well, you have chronic pain and you're on Percocet. I can't really hurt you, so why don't we double up your Benadryl and I'll give you some cannabis and we'll see what goes on from there. But unfortunately for me, they did develop more symptoms of rhinitis and allergic issues. So I had to stop the dried flower. And I didn't have extracts available because this is back in 2016. So I waited for the oils. And fortunately, there are some companies that don't do terpene addition into their oils. And due to that, I can use it for them. I can use the THC and the CBD to modulate their sleep and their anxiety and improve their quality of life. So we need the industry to acknowledge that there is a fundamental need for non-terpene products. Terpenes are important, but for some people they're not. Because guess what? These very women, you can't wear perfume around them. They have sensitivities to lotions and creams. You put latex near them and they have an allergy. Their immune systems are different. We are all different. We need to acknowledge these things. Now, avoiding inhalation and respiratory diseases due to delivery method is actually my reason. Not because you have COPD and you're a smoker and I don't want you to get lung cancer. It's because you can't breathe. I can't actually determine if you can actually get the dose in you. Makes sense, right? Avoid in less than 18 years of age. I have my issues with that, but I'll leave it there. It's, College of Physicians of Ontario says 25. Current history of schizophrenia or psychosis. If you're not a trained psychiatrist, don't treat people with underlying psychiatric conditions. Heart failure. Well, why is that so important? Well, in your heart, if you have had a heart attack and your pump isn't working, if I stress your body by lowering your blood pressure and increasing your heart rate, your pump doesn't work anymore, increasing your risk of a stroke or cardiac arrest. So, please, don't give THC first, because it speeds up your heart rate and vasodilates you. Not good for someone with heart failure. That's why elderly people with heart disease should not be going to a dispensary to get cannabis. Doctors need to be educating them about the fact that if you have tachycardia and vasodilation from an acute high dose of THC that you thought was a low dose because you just rubbed it on your gum, Sana-Ara so. It's not okay. It's not okay to not have conversations with physicians to understand the importance we play in education. Now, pregnant or breastfeeding, I have challenges with this as well, but I'll put it out there. There will never be a study to say to a woman who is pregnant and not pregnant that we're going to give you something and not give you something and then see what happens to your baby. The ethics don't exist. We as a society will not tolerate that we could potentially harm an unborn fetus for the fact that we want to medically experiment. That is why in pregnancy and breastfeeding, you don't give them anything. You literally don't give them anything. There's like 5 medications you can give a pregnant woman. That's it. Tylenol isn't even one of them. So I educate, discuss the potential side effects, educate on the psychoactive components of both. Talk about the fact that THC coming from a limonene and pinene sativa has an excitatory hyperarousal effect on you. Whereas a THC associated with high myrcene and alpha-cardiophyllene will have a relaxing and anti-inflammatory effect, will help you sleep. CBD works synergistically with THC and it mitigates the negative side effects. Well, guess what, guys? Guess what CBD does? It prevents your heart rate from going up. So remember that elderly patient who potentially could be at high risk with THC, if you prep them with 10 milligrams of CBD and then start some THC, you're mitigating or preventing that very issue that is happening. But how were they supposed to know that? Unless you educate them, unless you educate yourself. Licensed producers will label all products with a percentage of exactly the amounts of CBD and THC, which allows you then to determine the milligram dosing, which is very different than an edible product. Edible products, question mark. I take a gummy before I go to sleep. I've heard that so much in my office. What's in the gummy? I don't know. Does it make you sleep every night? No. Is that why you're here? Yeah. Okay, let's just cut to the chase and acknowledge that if we don't identify the exact dosing of what's happening in that edible, we are not determining your tolerance and we are not determining your actual impact of psychomotor slowing, because reaction time is affected with THC. What is its benefits? Neuropathic pain, nociceptive inflammatory pain relief. It will improve your well-being. Lo and behold, euphoria, something that we as a society cannot tolerate. We can't tolerate being happy. It's ridiculous. Drowsiness and sedation, muscle relaxation, an increase in appetite. If you are morbidly obese and have anxiety and chronic pain because of knee arthritis, and I'm actually increasing your desire to eat, I haven't done you a favor. I have not done you a favor, especially if you think it's okay to make an edible and it's not necessarily going to benefit you. Maybe the conversation should be a ketogenic diet and using the MCT oil of CBD as part of your ketogenic diet. That's the kind of conversations we need to be having with patients. Decrease in nausea, and last but not least, self-awareness and improved ability to engage in mindfulness activities. How many people in this room will raise their hand and agree with me that THC can improve mindfulness? Yes, at the right dose. At the right dose, a person can engage with their prefrontal cortex and regulate their ability to retrieve memories and become more mindful and self-aware. And when they become more mindful and self-aware, they can then use psychological tools to help them cope. But if they're so stressed out that they can't even get to the psychological tool, then it doesn't matter if they're going to a psychologist, in my opinion. Because the psychologist is working so hard, but they're not getting the opportunity to have the success. We put them on antidepressants and they're depressed. And then they're antidepressed. I don't even know what that means. Educate the patient on positive effects of CBD. Again, the same list, but I'll add in one more thing. Mental alertness, cognitive clarity, improved verbal communication, reduction of hyperarousal symptoms, can counteract the negative effects of THC, reduction in headaches, and no indicate of any abuse potential according to the World Health Organization. That's huge. So common acute side effects of THC that are reversible, diminish with tolerance, and are short-lived. Dizziness, lightheadedness, impaired motor coordination, dry mouth, red eyes, blurry vision, impaired short-term memory, perception of time and space becoming altered, known as psychomotor slowing, tachycardia, and peripheral vasodilation. All of this can be mitigated with low doses, as well as starting slow and combining CBD. Anything greater than 25% is going to make your heart rate go up. Don't start with sour diesel. It's got too high of a concentration of limonene, too. Just makes it work way too fast. Psychomotor slowing and short-term memory loss can be more than 1 to 2 hours after normalizing, which is why the mad commercials are out there. Don't drink and drive, don't smoke and drive, your impaired reaction times. Why are we not talking about pre-medicating with 50 milligrams of CBD? Why are we not mitigating the issue from the start? I am so frustrated that the conversation happening all around me, I'm having this opportunity, and I wish this room was full to the brim so everybody could know. If you take 50 milligrams of CBD, you are mitigating the risk of THC causing you harm. Why is CBD so important? Well, it's so important that we actually have an entire hemp industry out of it that we're failing to actually acknowledge should be part of our regular routine. I don't understand why we don't talk about this on a regular basis. Now, the cannabis poisoning that's happening in Emerge. Too much THC, well, let's just think about it. THC is the happy component. It makes your nausea go away, it makes you feel more relaxed, makes you want to go to sleep, and it increases your appetite. Take too much of it, can't go to sleep, makes your appetite worse, you start throwing up, and you're not feeling well. Makes sense, right? So, for people who start dabbing and using shatter and getting 90% concentrate of THC after the basics of THC that they've been getting from dried flower was maybe 20%, you've overactivated your chemo trigger receptor zone, which is part of the brain area that actually CB1 receptors are in, which is why in chemo-induced nausea and vomiting, you can improve the symptoms of nausea and vomiting in people who are sick, because a synthetic chemical was altering it. Now, you're overriding the system and now you're throwing up. Cannabis hyperemesis syndrome. Acknowledge it for what it is. Why are they not putting CBD in emergency rooms? Why are they not giving them 500 milligrams of CBD to override the system? Because CBD is too expensive? Because they don't know about it? I'm not sure. And profound sedation will occur within 20 to 30 minutes, if at all. And that's why I asked my patients to experiment on weekends, because if they don't want to sleep in the morning, don't do it the night before you have a big presentation. I'm fasting, so not relevant. Clinical pearls. Educate the patient how to use CBD to counter the effect of supratherapeutic THC. I don't call it poisoning, I call it supratherapeutic, because in the medical world, we have therapeutic indices, and we have something that fits within the nice therapeutic realm, and then it becomes supratherapeutic. And when it's supratherapeutic, it becomes associated with potential toxicity. But we have all identified toxicity means death, right? Toxicity means that you die because it's toxic to you. At least that's how I understand it. And if I remember correctly, about 15 slides ago, I said there's no recorded death. So it's not toxic, it's super therapeutic. That's how I think of it. Why would I even consider this an issue? Well, I face a lot of compliance issues in my practice. Why would you think that? Well, it's because the majority of my patients didn't know they were going to start cannabis. And when I do start cannabis with them, their biggest issue is non-compliance, because if they took too much and they felt uncomfortable, nah, I don't want to feel like this. Okay, well then let's talk about CBD, and actually sounds like you're not taking enough of it. Why are you not taking enough of it? Because it's too expensive, but that's a different topic. Twice the amount of CBD in concentration doses within 15 minutes of vaporized administration can reduce the side effects by approximately 20 to 50%. And the reason why I know this is I do it in my office. I'm probably advertising something I shouldn't, so keep that on the down low. But when my patients are feeling agitated, I ask them to take more CBD to prove to themselves and to me that they get better. Initiating CBD in the background at 5 milligrams every 4 hours, up to 12.5 milligrams will work. I'm getting a slight signal that I have to end. 2 more minutes. Yeah? Yeah, no problem. Variety, dose, vaporization versus oral. No smoking, please. You're burning your money away. You literally are burning your money. Why do you want to burn your money? I like money. I don't want to burn my money. Vaporization makes sense. It's sublimation. You are converting a solid state into a vaporous state. You are converting a liquid state into a vapor state through heat in a ceramic pot, which is allowing that to happen. So then you're not actually harming your lungs or your throat with carcinogenic compounds, because when you burn something at over 1800 degrees Fahrenheit, you're burning your throat too. And as a physician, smoking is not okay with me. Ingestion, it takes up to about 2 hours in some people. Depends upon your liver as well. So if you've got liver disease, you've got to be careful with that. Onset, 5 minutes. With inhalation, 15 minutes peak. Duration, 2 to 4 hours. You take an edible oil, up to an hour and a half. Peak effect in about 1 to 2, 3 hours, lasts up to 6 to 8 hours. Short acting, long acting. We're all conditioned to think like this. Educate on harm reduction strategies. Do use the lowest dose of THC and optimize your CBD to reduce any psychomotor impairment. Do not smoke, and do not drive within 4 hours of inhaling or 6 hours after oral ingestion, because if you don't know how it feels in you, you may be impaired. Do not use it with alcohol and other sedating drugs because there is a compounded effect on sedation. Cannabis and driving, I don't even know where to go when it comes to this, but for right now, just don't do it. Education on traveling within Canada. So, 2 key points if you did not know this. Your green card, useless. Useless for traveling with you. You actually need the receipt of purchase from the licensed producer to prove that you are in legal possession of cannabis. I do not care if you go with your green card to online dispensaries and purchase your cannabis. It's illegal for you, and if you get caught at any security checks or with the police, you're in trouble. But if you have a receipt from one of over 70 licensed producers, there's enough cannabis in Canada, guys, trust me. There's enough cannabis in this country. But if you have proof that you ordered it, and you've got the medical document from your doctor, and you have the containers of cannabis or the bottles of oil, can't be bothered. You will not be bothered. I have been a witness to hearing my patients share with me that by virtue of me sharing this knowledge, how their travel within Canada has been seamless, and how they have never been bothered by anybody because they knew how to travel with it. Take-home messages. Start low, go slow. Use lots of CBD. And I guess take-home message, contact my office if you have any issues. Lots of references. Thank you so much for being such a great audience.